then you can stop sharing and share again.
Now
it's good.
Yes. So I'll start.
Yes, yes.
They'll be answering in the chat box.
Yeah, can you see the chat box?
Just open it. Yes.
Okay, so let's start.
So in combined score, the score ranges from A 0 to 10, B 0 to 7, C 0 to 17, D 0 to 27. So, how much time is given to give the answer? Many have answered.
Yeah, maybe a minute or so.
Okay. Okay, I think it's 1 minute. So 3 of them answered correctly. The answer is C, 0 to 17. Most of them answered answer is A. So coming to discussing this. So answer A would have been correct if the question was conventional APGAR score. So this is the conventional APGAR score which was given by Virginia APGAR in 1953, as we know, which includes heart rate, respiration, muscle tone, reflex irritability, and color, and each of them having 0, 1, and 2 as the score. So this score becomes out of 10. But then there were 2 difficulties that were felt. One was you could not apply it to premature babies when the gestation was less, as your grimace reflex or the tone could not be assessed that properly. Second was whenever we resuscitated babies or any intervention was required, again it was difficult to put a APGAR score to that whenever we gave bag and mask ventilation or intubated the baby. That is why these 2 other scores that came into existence. One was a specified APGAR score, which you can see lower down, which is the same as our conventional APGAR score. However, certain things were changed in that, so as that premature babies also could be included. So skin color was same, 2 for pink, 1 for acrocyanosis, and 0 for pale and blue. Heart rate was also same, that is 2 for more than 100, 1 for less than 100, and 0 for no heartbeat. However, grimace reflex was changed to 2 as appropriate for gestational age, and 1 was reduced for gestational age, and so 0 as no reflex. Similarly, again, appearance and muscle tone, instead of active moving and partially flexed and totally limp, it was made into 2 as appropriate for gestational age, score 1 for reduced for gestational age, and 0 for no reflex. And respiration, instead of taking it as respiration, it was made into chest movement for regular chest movement, small or irregular chest movement, and no chest movement. This was called as specified APGAR score. So again, you get a score of 10 here. Coming to expanded APGAR score, you can remember it by mnemonic combine itself. C for CPAP, O for oxygen, MB for bag and mask ventilation, I for intubation and ventilation, N for neonatal chest compression, E for exogenous surfactant, and D for drugs. So when an intervention was performed, you give 0 score. And when intervention is not performed, you give a score of 1. Only thing here you have to remember is that when you give CPAP, when you give bag and mask ventilation or CPAP, when you give CPAP, you have to automatically score 0 for bag and mask ventilation also. And when you are already intubating, you have to give a score of 0 for intubation also. So this score comes to total of 7. So combined APGAR score is combination of expanded and specified APGAR score. Thus total score comes out of 17. Coming to the next MCQ. Which condition has the short time constant? A, RDS, B, MA, that is respiratory distress syndrome, B, meconium aspiration syndrome, C, bronchopulmonary dysplasia, and D, both B and C. Yes, so I think most have answered correctly here. So answer is A, RDS. So basically, what is time constant? So time constant is a measure of how quickly the lungs can inflate and deflate in simple terms. So it is how long it takes for the alveolar and the proximal airway pressures to equilibrate. So this time constant is given by a formula, that is, it is compliance multiplied by airway resistance. Now, it takes one time constant to empty 63% of the lungs. And then it takes 3 time constants to empty 95% of the lung tidal volume. So suppose we take compliance as 0.005 and airway resistance as 30. That means time constant here will be 0.15 second. And when you take 3 time constant, that is for the total airway system for the pressures to equilibrate, it comes to 0.45 seconds. And that is why most often when we have ventilator settings and we decide to set our I time, this is how we come to that number. Now coming to RDS, now we know that the formula for time constant is compliance into airway resistance. Now in RDS you have stiff lungs. So when you have stiff lungs, the compliance is very much reduced in RDS. Now, normal, which is around 0.005 to 0.006, in RDS it will be as low as 0.0005 to 0.001. So since the compliance is so low, the time constant is less. So that is why when you are managing RDS, you will require higher respiratory rates with a shorter I time. Now, when it is meconium aspiration syndrome or bronchopulmonary dysplasia, you have a very, very high airway resistance. And that is why you have a higher time constants. And that is why you will be keeping lesser ventilator rates. So coming to third question, Fortification of human milk based on macronutrient component of breast milk is termed as? Okay, so here again most have answered correctly. So answer is targeted fortification. So basically when we say standard fortification, that is what most of us practice and it is practical, and that we fortify, whatever we fortify is we assume the milk content of carbohydrates, calories and proteins, and based on that, directly based on response of the baby, whether there is weight gain or not, or whatever protocols that we follow in our NICU, we do fortification. Other method of fortification is individualized fortification. One is adjusted fortification, wherein you look for protein adequacy by measuring blood urea nitrogen levels weekly or bi-weekly, and target should be around 10 to 16. And when it is less than 10, then you consider there is inadequate protein. And that is when you decide to fortify. Targeted fortification is when you have macronutrient concentration of human milk analyzed using milk analyzers, and based on how much, and then you exactly decide whether you want to do a single nutrient fortification or multi-nutrient fortification. So that is what is targeted fortification. Coming to the fourth question. Standard reporting guidelines for meta-analysis is called? So again, most have answered correctly. So answer is Prisma. Why I put up this question is, this question is almost always asked in, at least one question in this category will come in the fellowship exam. So try to know all of these tests, the standard reporting guideline. So answer was Prisma. You have to remember here that Prisma is for systemic reviews and meta-analysis of interventional studies, and MOOS is for systematic reviews and meta-analysis of observational studies. Then you have consort for randomized control trials, stroke for observational studies, and START for diagnostic studies. So one of these questions is almost always asked in fellowship MCQs. So you should know either full forms or what each standard reporting guideline means. And the last question is home-based newborn care guidelines. ASHA visits the baby at home till what age? Yes, again, I'm happy many have answered correctly, because you will be asked questions from something from community, something from statistics will come. One of those reporting guidelines would be asked, and definitely like time constant, some physiological principles in ventilation will be asked. And because most of us will read clinical neonatology, and those most of us will be able to answer. But if you have some basic reading in community neonatology, statistics, and those physiological principles, you'll be able to score in those areas. So coming to the correct answer is B, 6 weeks. So during home visits, ASHA home visits are for institutional deliveries. The first visit is on the 3rd day, second visit is on the 7th day, third visit is on the 14th day, fourth visit 21st, fifth visit 28th, and sixth visit 42nd day. So that comes to 6 weeks. And when you have a home delivery, then there is an additional visit which is in the first 24 hours. So if you are asked how many visits, then there are 6 visits. If it is a institutional delivery, it becomes 7 visits when there is a home delivery. And this is home-based newborn care. And then there was a home-based care for young child, wherein now ASHA is going to visit from 3rd month till 15th month of childbirth. Yes, thank you. Yes, ma'am, we are done. Yeah, thank you.
Yes. Thank you, Dr. Sarvesh. It was a good session to learn from you. I must mention here that Dr. Sarvesh is a DM in neonatology, but in addition to that, Sarvesh is also a